My name is Ayo and I'm back again with another video. So like I saying on my other videos, this is a gentle reminder if I talk too fast to just reduce the speed, YouTube has that option. And let's get right into it today. So today we're going to be talking about how to answer these first questions on the ASWB exam. So I have a little breakdown of things to look for and prioritize, as well as I have some practice problems on the bottom. So what I want to say, I have this like priority ladder, but what I want to say is that sometimes it's not going to be this straightforward. You just got to remember what is taking priority. Safety always comes first. If you have a person who recently lost somebody and they're telling you they feel hopeless, they don't want to be here anymore, more than likely it's going to be something about safety. Assess for suicide, assess for self-harm, assess for something like that, right? If somebody just experienced a whole bunch of loss, they are more at danger of wanting to exit this world. So you want to make sure that you are assessing for safety. Next, the medical stuff. So in these questions, right, when you see something that someone has an unexplainable weight loss or they have headaches and migraines and they haven't seen a doctor yet, the answer is going to be refer them to go see their MD, refer them to go see their primary care doctor. We want to make sure that we're ruling out anything physical before it's psychological. Substance use. So with substance use, if a person has a substance use issue, you want to refer them out before they do any kind of therapy. They need to be in a substance use program. That always takes priority over individual therapy. They want to be in some type of program. So if you see a question like that, like a family comes in and let's say the mom has a substance use issue and you're trying to do family therapy, the answer is going to be something like refer the mom, coordinate the mom to go get into substance use treatment, or whatever wording like that. You got to remember that. Next, mandating reporting. Also, too, I want to highlight with the substance use, if it's active substance use, not that they're in recovery, if they're actively using, that's when you're going to refer them out to some type of substance use treatment. So mandated reporting, we are mandating reporters, okay? If someone is engaging in elder abuse or neglect or child abuse or neglect, we have to report. I know that sometimes when people are going through the questions, they think that, oh, mandated reporting is too extreme, but we have to. In these questions, you have to. If you see something like a child has bruises that are unexplainable, and you talk to the child and they don't want to talk about it, something like that, or a child tells you that their mom ties them down at night because they don't want them to be walking around, or they say that they tie their parent down at night because they walk around because they have dementia, we got to report it, okay? We have to report it. So you want to think about that. Sometimes they give you clues. It'll say like a 7-year-old came in with bruises and this and this. What's the first thing you do? Report it. We're reporting because we're mandated reporters, okay? Then after you go through those things, after that, that's where it's the validation or acknowledging, validating a person's ambivalence, validating a person's emotion. After we validate, then we assess, right? We need more information. Somebody comes in, they're having some kind of symptoms of a diagnosis, and it's like, what do you do next? There's no sign of that they're at risk for trying to kill themselves. There's no sign that they use substance use. Then the next thing you're going to do is you're going to assess. Then the last thing you probably do is educate. I haven't really seen too many questions about psychoeducation or things like that, but that is the last thing, right? You educate or you do an intervention. Referring can happen at the top of the list, right? Referring them to go see a medical provider. Number 7, when it says refer, it's like more so like referring them to go see, let's say, another specialist. Let's say if you see a question stem that talks about you get a patient that has complex trauma and you're not trained in any kind of trauma modality. What do you do? What's the first thing you do? Okay, right? Let's say this is a new patient. You just doing an intake. What do? You're going to refer them to go see a specialist. You haven't built that therapeutic rapport yet. You haven't been working with them for months. You're going to refer them out to go see someone. We are technically not supposed to be working with people that we are not competent to work with. We don't take on cases that we don't have training in, or we don't feel, or let me not say feel, but we're not competent. We're not properly trained or supervised to do that kind of therapy or that kind of work. Okay, I hope this all makes sense, right? So this priority ladder, it's not the end all be all. It's just things that you want to think about when you are answering these first questions. If you can think about these things, it's really going to help you kind of figure out where to go next. Because a lot of times with these first questions, what they do is that they're going to have answers that all can be correct. But it's asking you what do you do first? And you want to ask yourself, what am I doing first? If somebody's coming in and there's abuse, I am calling and doing a mandating report. If somebody comes in and they're trying to kill themselves, first thing I want to do, suicide assessment. Or if they tell you that you did a suicide assessment and a person's committed to live, then we're going to do safety planning, right? You just want to ask yourself, what do I want to do first? Don't get tripped up because all the answers can be correct. It's asking you first step. And if you can think about this priority list in the first step, it's going to make these questions a lot easier. So I have some examples and I wrote out why. So when suicide comes in, suicide thoughts, plans, or intent, we first do a suicide assessment, right? We do safety planning. Why? Because safety is always going to be the top priority. Let's say there's a question that talks about someone that has substance use, but let's say they also are feeling hopeless and want to kill themselves. We're doing the safety is going to be the answer. We know the substance is there. If we didn't have an option for safety, then substance would be the answer. But when it comes to suicide and somebody want to kill themselves, that always takes priority every single time. Don't get tripped up. Remember, sometimes they won't even tell you that the person wants to kill themselves, but they'll say things like hopeless, or the person just experienced a whole bunch of losses, right? They lost their job, they lost their partner, they don't have any money. They're telling you want to safety. Safety is coming in. You want to do a suicide assessment. Don't get tripped up. Having active abuse, so elderly abuse or child abuse or dependent abuse, we report to CPS or APS. We are mandated reporters. Got to remember that. Domestic violence. When a couple is in domestic violence and they want to go to therapy for couples treatment, we don't do that. If there is domestic violence going on, couples therapy is not going to be helpful. They both need to go to individual therapy to explore. By having couples therapy when there is DV going on, you are putting the person at risk for more DV, for more violence. Okay? It can put them at more risk, so we don't do that. So substance use. Like I said earlier, when there's active substance use without any safety concerns, we are coordinating treatment to get them into addiction treatment. Okay? If a person is experiencing unexpected weight loss or fatigue or headaches or having medical complaints and the question doesn't say they saw their doctor yet, you're referring them to go see a doctor. Because sometimes the question will say things like, oh, the doctor sent them to you. Make sure you read that and you remember that. If the doctor sent them to you, that means they ruled out all kind of medical concerns. So now it might be something like a conversion disorder or somatic disorder, something like that. You want to think about that. So after that, right, if the client is visibly distressed or expressing irrational beliefs or expressing ambivalence, then we want to validate and acknowledge and reflect. And then after that, if a person is needing some psychoeducation or something like that, then we do that. Also, something I want to highlight that when it comes to grief, because in the DSM there's a new grief disorder. When it comes to grief, we want to normalize, we want to validate, and we also want to assess the duration. Not all grief is pathological, okay? So we want to assess that first. So I hope this explains it well to everyone, and I hope I said it in a way that makes sense. So now we're going to get into some practice problems, and I'm going to try my best to take my time on why the answers that are wrong. Okay? So question number 1. A couple seeks therapy due to frequent argument. One partner says the other has hit them during fights. What should a social worker do first? So should we explore the couple's conflict resolution skills? Should we refer each partner to an individual therapy? Should we begin a couples counseling session? Or should we contact law enforcement? Okay. We know that we're not beginning couples counseling because I just said why. We're not going to do that. So C is out of the picture. Couples counseling can escalate the risk. The answer is not A, because exploring skills bypass addressing the domestic violence. And we're not doing D because law enforcement is not an immediate step. We're not breaking confidentiality for a DV case. The only way that we would break confidentiality if, let's say, one partner says that they're going to go kill their boss tomorrow at 9 p.m., right? They have a specific person, a specific time. Then we have to break confidentiality and report that to whatever the state's requirement is when it comes to confidentiality. So the answer here would be what? We are referring them to go to individual therapy. So the answer would be B. Okay, highlight. In individual therapy, that's going to be safer for each of them to explore what's going on. You wouldn't do that together. Couples counseling would be out. So that is why the answer is B. Next question. A 25-year-old woman presents with fatigue, tearfulness, and unexplained 15-pound weight loss over 2 months. She hasn't seen a doctor in years. She denies any kind of suicidal ideation. What do we do first? So are we administering PHQ-9? Are we beginning CBT treatment? Are we gathering psychosocial history? Or are we referring her to go get a full medical examination? Here, this person hasn't seen a doctor in years. They're feeling fatigue. They're feeling tearfulness. This may be a biological thing, physiological thing. So what we're going to do is we're going to refer them to go get a full medical evaluation. Now, let's say if this question was switched and it said that the person already seen a doctor. We need to gather more information, okay? So we may do D and gather more information because the person hasn't seen a doctor. I mean, the person saw a doctor frequently, or they saw a doctor. It hasn't been years since seen a doctor, so maybe we need to explore something else and get more information to properly assess what's going on. So let me explain a little bit more why the other answers are wrong. So with the PHQ-9, that screens for depression, but it doesn't really rule out any kind of physical causes. Starting therapy assumes symptoms are psychological without ruling any kind of medical rule out. And the psychosocial history can be helpful, but it doesn't address the physical health red flags. That's why C is the correct answer. Okay, next question. A 9-year-old boy tells the school social worker his aunt locks him in the bathroom when he gets too loud, and sometimes for hours, and he misses meals. What do we do first? Okay, so are we calling the aunt to hear her side? Are we contacting CPS? Are we asking the child to clarify what too loud is? Or are we talking to the school principal? So it wouldn't be A. We do not need to confirm the story before reporting. It wouldn't be C. We don't need him to clarify anything when it comes to us doing a mandated report. And it wouldn't be D. Consulting with others isn't necessary and can delay time in reporting. So the answer here will definitely be B. We're contacting CPS. Next question. A client tells a social worker that he has been feeling worthless and started thinking about how easy it would be just to not wake up. What should the social worker do first? So should we recommend the client attend a CBT group, refer the client to a psychiatrist for medication, conduct a suicide assessment, risk assessment, or validate the client's emotional pain? So the answer definitely would not be A. Group is not appropriate or important before assessing risk. This person is saying how easy it would be to just not wake up, okay? B may come later, right? We may refer them to go see a psychiatrist later, but that's not the first thing that we do. And with validation, right, we can validate and acknowledge the person's pain, but that comes secondary to assess safety risk. So the answer here would definitely be C. We conduct a suicide assessment. Somebody saying they don't want to be here or how easy it would be to not wake up, that's suicide ideation. We want to explore that. We want to do a safety risk to make sure and see what's going on and make sure the person is committed to live. Okay, next. A social worker, well, I'm gonna make sure I didn't miss any question. Okay, good. A social worker at a community agency meets with a 82-year-old woman who reports that her adult grandson, who lives with her, has been handling all her money and recently got angry and shoved me when I asked for some of the money back. Okay? She appears fearful and avoids making eye contact. What should the social worker do first? So we have an elderly person, their grandson handling all their money. They got angry with them and they shoved them. When they ask for the money back, what are we doing first? Are we exploring the dynamics of the relationship with the grandson? Are we filing a report with Adult Protective Services? Are we referring the client to a financial counselor? Are we providing the client with a list of shelters and legal aid options? So this is asking you, what is the first thing we do? We may eventually do all these things or some of these things, but what's the first thing we do? So exploring the dynamics of relationship with the grandson may be helpful later, but it further delays what we need to do. Okay? Referring the client to a financial advisor or counselor doesn't address the safety risk or the abuse that's going on. And providing the client with a list of shelters may be something that we eventually do after safety planning, but the first thing we need to do is file a report with Adult Protective Services. So those are all the questions I have today. I hope this was helpful. I hope it was straightforward. I hope you learned something today. I'll be back real soon with another video. If you have any questions, please send an email or leave a comment, and I'll see you all real soon. Bye-bye.